Hi, this is a video lecture on perfusion, specifically targeting the hypertensive disorders that occur in pregnancy. It is a very common complication, about 10% of all pregnancies worldwide. It's also a leading cause of maternal and perinatal morbidity and mortality worldwide. It's actually, the incidence is increasing by 25% in the last 25 years. So going along with your PowerPoint, we're going to be talking about some of the hypertensive disorders that we see in pregnancy, and the first one is gestational hypertension. Gestational hypertension is that it happens in pregnancy. It happens after 20 weeks pregnant without proteinuria, so no protein in the urine, and it resolves by 6 weeks postpartum. The other one is called preeclampsia, which we're going to spend a lot of time with, and that happens after 20 weeks. It does have proteinuria, and it's new onset hypertension after 20 weeks. Eclampsia is the progression of preeclampsia. You don't necessarily have eclampsia with every pregnancy. You want to prevent that, but that is like the seizure portion of the disease. And then there's chronic hypertension, which either predates the pregnancy, where hypertension happens before 20 weeks, but it goes well beyond the postpartum period. So that is in itself is a different disorder. And then you have preeclampsia that's superimposed with chronic hypertension, where you have both preeclampsia and chronic hypertension, which is a little bit more ominous. It's significant worsening of blood pressure, proteinuria, and some have some severe features. And that's what we're going to be talking about. So who is at risk for preeclampsia is the first-time moms. We call them primips. The old and the young, so less than 19, over 40. If somebody's had a severe preeclampsia in a previous pregnancy, their risk for having it again is good, especially if it's with the same partner. A family history, but like your mom or your sister. The paternal history, if a father of the baby has fathered a previous pregnancy where there was preeclampsia involved, it might be him. African Americans, just because of their increased risk factor for hypertension. Those with chronic hypertension or renal disease, moms that are diabetic, because that's also a vascular disorder, more than one baby inside, being overweight, and any of those immune disorders like Crohn's or lupus, clotting disorders, that puts them at risk for this. And then also if it's a first pregnancy with a new partner, because that changes like the DNA. So preeclampsia, what is it? So it is characterized by maternal vasospasm, which is increased blood pressure, and decreased perfusion to virtually every organ. So the brain, the liver, the kidneys, the placenta, all of that. Okay, as in your post PowerPoint, couldn't get that out. Major cause of perinatal death. The exact cause is unknown, but what they're saying is that it is an abnormal vascular response to implantation. So it goes all the way back to the blastocystic stage. So during implantation, it's an abnormal vascular response to that. So you're destined right when you first get pregnant on whether or not you're going to get preeclampsia or not. It only happens in gestation. It could increase your risk for coronary artery disease in the future. It disappears quickly after delivery. There isn't really any evidence-based planning screening tool that's available, but early key is really important. So signs and symptoms can change just like that. So that's one of the things that we're going to be talking about. So when we talk about pathophysiology, it's maternal vasospasm, decreased perfusion to virtually every organ, and really the cure is delivery, which becomes a problem if you have somebody who is really sick at 24 weeks. So the there's a vasospasm that occurs in the arterioles, which injures endothelial cells, so platelets aggregate. Fibrin deposits are laid down, and blood vessels decrease in diameter, which lyses the RBCs and decreases blood flow to all organs, therefore increasing blood pressure. So vasospasm. You're going to see a chart in your PowerPoint that looks just like this, and it talks about preeclampsia without severe features and with severe features. And you can see where, like, without severe features, it's a blood pressure of greater than 140/90. Severe is 160/110. Proteinuria, and this is not a typo, it's 300 milligrams in a 24-hour period versus 5 grams in a 24-hour period. Reflexes can be normal without severe features, but hyperreflexic with severe with severe features. You can see urine output could be normal versus it could be less with severe. Also with some of the symptoms like headache, visual changes, irritability, epigastric pain. You can see just some of the things, the differences between without severe features and with severe features. One of the things too, as far as the fetal effects, it decreases placental perfusion, so therefore you might have a baby that's very small. You might have a baby that is chronically hypoxic. It could cause we just learned about abruption, so the increasing blood pressure could cause an abruption. Late decels, because we're talking about uteroplacental insufficiency. So if we have decreased perfusion to the placenta, therefore it's going to cause decreased fetal oxygenation secondary to uteroplacental insufficiency. So you will have late decels. You probably will have minimal variability at some point. And then also you'll see premature placental aging. So for those of you who had the opportunity to play with the placenta, you might have seen the white infarcts where it almost looks like the marbleness like of a steak, kind of like. But basically that whiteness is that infarct. And sometimes we can tell if a patient smokes or if the placenta is starting to age. So again, you might see small size of the placenta, and you might see like that whiteness, that marble appearance in the placenta. So the goal, according to on your PowerPoint, we put it, the goal is to promote placental perfusion and fetal oxygenation every single time for every single patient. And to keep the patient stable with no, we don't want them to have a stroke, okay, or a seizure. So if you want to stay at home with a preeclampsia without severe features, it doesn't mean that you're home to do laundry and to vacuum and take care of the kids and prep all these meals. Your job is really to kind of sit your butt on the couch, get up to go to the bathroom, get up to go get something to drink, get up to go get something to eat, and then back to the couch. It's not anything else. It's important that you weigh yourself daily. So like a sudden waking of like 10 pounds, blood pressure increasing, making sure that the baby is moving okay, checking your urine for protein, resting, diversional activities. So just kind of sitting at home doing like Wordle. I'm not sure what you're going to do. We want to get patients to 37 weeks if at all possible so that we can induce them. A lot of times we have to deliver them beforehand. Now, one of the things is if you understand the etiology that if it's decreased perfusion to virtually every organ, then that is going to kind of manifest how your nursing interventions are going to go. So 3 questions that you're going to ask your patient is 1, do you have a headache? 2, do you have any visual changes? 3, do you have any epigastric pain? Those are 3 questions that you're going to ask because we know that there's decreased perfusion to the brain. We know that there's decreased perfusion to the liver, which could cause like hematoma, and that's why they might have that epigastric pain. Decreased perfusion to, so moving your way down, lungs. Okay, so you might have, if you're on medication, we'll talk about the medication, but you want to make sure that patient is alert, is oriented ×4, they're breathing, their lung sounds are clear, they're 12 or more as far as a respiratory rate. You're going down, you're looking at the fetus and the uterus, okay? So you're looking at the heart rate. Is it minimal? Is it moderate variability? Is there accelerations? Are there late decelerations? Is she contracting? What's going on with this baby? We know that there's decreased perfusion to the fetus and to the placenta. Then going on, you're going to check urine output. We know there's decreased perfusion to the kidney, so therefore you might have decreased urine output. You might have upper extremity edema, okay? We don't worry so much about lower extremity edema any longer just because that's normal. People are up and walking. But if your face is puffy or if your hands or arms are puffy, we tend to worry about that a little bit more. We look at reflexes. We can do upper extremity reflexes or lower extremity reflexes because we know that there's decreased perfusion to the CNS system. Clonus is, you can see it on one of your pictures, and we'll talk about it in classes. If this is my foot and I take it and I flex my foot and I just kind of let it go, if it beats back, that's what we call clonus. And we have beats of clonus that tells us that our CNS system is very irritated and the chances of a seizure is greater. Okay, so the biggest thing is that you want to just kind of do like a cephalocaudal approach and just looking at our patients, and especially when they are being diagnosed with preeclampsia. The job of us is to sorry about that. The job for us to do is to stabilize and deliver. Okay, so you're going to listen to their breath sounds. You're going to ask them those questions. You're going to look at their INO and about proteinuria in their urine. So you're going to go all the way through. So again, also pain. Is she abrupting? Those are, because people with preeclampsia are at a higher risk for that. Okay, so labs. We're going to do a CBC because we want to know what her hemoglobin, hematocrit, her platelets are. We're going to check her clotting factors. We're going to check a protein creatinine ratio. They might do a 24-hour urine. They might do some other coags. Some other things that we might do is a uric acid. A uric acid is kind of an early indicator of whether or not somebody is getting preeclampsia or not. One of the things we do is we give magnesium sulfate. Magnesium sulfate in preeclampsia is the medication that we give to prevent seizures. And that's by blocking neuromuscular transmission. It's not an antihypertensive, but it relaxes smooth muscle, therefore having a secondary effect sometimes on blood pressure, which is nice. So it reduces that vasoconstriction, resulting in a modest drop in the blood pressure. So the decreased vasoconstriction should promote circulation to that placenta, into that organ, into that uterus, and hopefully we'll see a difference in that baby. We might induce them. If they're early enough, we might have to give them steroids. There's other medications that we can give, and if you look on your PowerPoint, it talks about activity is bed rest. You want to have a quiet environment. You want the side rails padded in case she has a seizure. You want to make sure that you limit the visitors, you limit like the stress that's in the room, because anything could kind of trigger, her worsening preeclampsia. But there is other medication that we give. And if you have chronic hypertension and preeclampsia, there's other meds that we give. Magnesium is still like our standard, but we might give Procardia. Now, I know you guys have heard of Procardia. Nifedipine, it's a calcium channel blocker. So if you think about that with a muscle, it kind of blocks the calcium into the cell. Also, we might give labetalol or hydralazine if we're in a hypertensive crisis. We might have to give steroids. I mean, there is just so many things that we can do, that we try to do to keep this patient pregnant. Now remember, the best intensive care unit for a fetus is inside mom until it's not. There is some situations where blood flow. So if you recall, when we were in antepartum, we talked about Doppler flow studies. And I said, we'll talk about this later. And that is what this is for. We want to know if there's so much pressure and vasospasm that's going on, sometimes the flow of blood and oxygen and nutrients through the cord from the maternal unit to the fetal unit is either very slow, it stops, or it's reversed. So in that case, we have an intrauterine growth restricted child, which is going to need to be delivered quicker, sooner than later, okay? The problem with magnesium sulfate is that magnesium sulfate is excreted in the kidneys. So if you have decreased perfusion to the kidneys, you're not going to get rid of that. So what happens is that the magnesium builds up. So that is what we worry about, magnesium toxicity. And you have to look for signs and symptoms like changes of level of consciousness. You might have to look at respiratory rate, loss of reflexes, just for an example, okay? Respiratory depression, cardiac arrest, God forbid. However, the antidote is calcium gluconate. Oftentimes, patients, we can just have to turn off the magnesium. We don't normally do MAG levels because the MAG levels are way up, and they have to be way up for them to be to work for us, okay? So sometimes we'll do a MAG level if somebody's really kind of like their level of consciousness has really changed. But other than that, sometimes we can just, turn it off, and it has a very short fast life, so patients rebound pretty quick. However, if you got some respiratory issues and you got some level of consciousness changes, you are definitely going to use the calcium gluconate. Let's see what else. So that is preeclampsia. So understanding the etiology, decreased perfusion to every organ, and then moving forward with your assessment. And we're going to practice that in our simulation that's coming up, as well as in class when we go through that virtual simulation. Okay. Eclampsia is the seizure portion of the disease. Not everybody, most people don't get to this. Some people just come in and they're seizing, and we never knew that they had preeclampsia. Most seizures happen in interpartum or within 24 hours after delivery. So that's why if you have preeclampsia, you're on magnesium for 24 hours after delivery to decrease the risk of seizures. They can also happen in antepartum. Seizures typically begin with some facial twitching followed by like the whole body being very rigid. Tonic-clonic movements then begin, and it lasts approximately about a minute. During a seizure, your respiratory system kind of ceases for the duration of the seizure, and that's due to kind of like that muscle spasm. So fetal oxygenation is obviously compromised. Breathing resumes with a long, noisy inhalation, and then sometimes there's like a coma, or sometimes there's just like this decreased level of consciousness that follows. So it's really important that we reorient them because they're not going to remember the seizure. There might be some transient fetal heart rate patterns directly after a seizure. There might be some fetal tachycardia as a baby tries to recover. So one of the big things is safety. Okay, so if you look at the acronym seizure, so S is for safety. So again, making sure the side rails up, the pad rails are side rails are padded. E is established and maintain the airway. So we don't turn the patient. You like maybe just turn their head, making sure that you have suction and oxygen available. I guess the other thing too is make sure that we do an IV bolus of mag. Even if they're on mag, we'd give them another bolus if they are on magnesium. If they're not on magnesium, we bolus them with magnesium. And then Z is like zealous observation, document seizure activity, the time that it starts, the time that it ends, any type of response, like what happened right before, what happened right after, making sure that you're re-evaluating mom and baby afterwards, like taking blood pressure, reorienting her. And again, that's going to be the topic of our high-risk simulation coming up. And then U is uterine activity. Observes for signs of precipitous labor or spontaneous rupture of membranes. Look for contraction pattern because of the muscle spasms that happen. And then R is rapid resuscitation. Again, you might have to prepare your patient for more sedation. You might have to artificially ventilate them. And then evaluate the fetus too. Okay, so monitor the fetus for non-reassuring fetal status, and you might have that initially, but hopefully it'll change the more that she's out of that. Typically, Pitocin will be needed to establish a vaginal delivery as magnesium relaxes the uterus, so they're going to need Pitocin too. We can use methods to ripen the cervix, based on her clinical history. We definitely want a vaginal delivery if at all possible, but sometimes that's not possible. Magnesium can cause the newborns to be respiratory distress, so we would always have our NICU or some type of pediatric specialist there at the delivery. And that is really it about, eclampsia. There is a whole, one of the things that we do is that you just want to maintain safety and make sure that you have oxygen and look at the time. And that's pretty much the big deal with that. Your PowerPoint has some pictures of, just like on eclampsia and what we do. Another form of preeclampsia with severe features is called HELP syndrome. And if you look at the acronym HELLP, it means hemolysis, elevated liver enzymes, and low platelets. These people are typically sicker than those with the preeclampsia with severe features, even though those guys are pretty sick. These guys are sicker. They're more that colicky, feverish. They have like the malaise. They got the tenderness over their liver. And sometimes we have to deliver them even before 34 weeks. Sometimes we'll give steroids. We just do our best to keep them, pregnant as long as possible. Okay, so the big thing here is they lower their platelets. So just making sure that we are monitoring our patients very closely for preeclampsia or the eclampsia signs and symptoms. One of the things too is, like, remember in the one of the first slides, it talked about preeclampsia without severe features with a blood pressure of 140/90. So One of the things that I think happens too is if you have somebody who starts their pregnancy with a blood pressure of 107 over 70, let's say, and by the time they're at the almost to the end of their pregnancy, they're like 128 over 80, and they're complaining of headache and stuff like that, and they have that upper extremity edema, they're preeclamptic because that is a significant change from where they started to where they ended. So I think that's one of the big things we get caught up on, numbers and parameters. And the thing is, you need to really look at your patients. That's it for this one, and I'll see you in class.